Hi everyone, Dr. Beena here. Today's revision topic is renal function test or the kidney function test. The kidney has got important functions of excretion of water and metabolic waste products from the body. And the functional unit of the kidney is nephrons. And the important functions of the nephrons are filtration, tubular reabsorption, and the tubular secretion. And each renal corpus cells consist of a glomerulus, which contains afferent and efferent arterioles, then the glomerular or the Bowman's capsule, and the Bowman's capsule receives filtrate, and then there are proximal convoluted tubule which reabsorbs the water and solutes, and loop of Henle or nephron loop which has got an ascending and descending loops, and then they regulates the concentration of urines. Then there is a distal convoluted tubule and the collecting tubule where the reabsorption of water and electrolytes takes place, and also action of certain hormones like antidiuretic hormone, aldosterone, and atrial natriuretic peptides are active. Then there is tubular secretion also. So generally these are the functions of a nephron. Now I will pass on to the actual kidney function test. To assess the kidney function, there are several tests which are performed after, and they are classified into several groups. So here classification is like this. Major renal function tests are classified. First one is the urine analysis, where physical, chemical, and the microscopic examination of urine occurs. Then second is the serum markers of kidney function, where the serum creatinine, serum urea, and the blood urea nitrogens are all estimated. And then the estimation of glomerular filtration, that is GFR, that is done by creatinine clearance, urea clearance, and urine clearances, that is various types of clearance test. And then there are tests for the tubular function, mainly urine concentration test, urine dilution test, and the urine acidification test. So whenever you are asked to write about the renal function test as such, you have to classify according to this classification and write each one separately. Okay. Now the urine analysis, it is a non-invasive and inexpensive test. Normal properties are well known and easily it can be measured by collecting urine sample and exam. So the physical characters are volume of urine, appearance, odor, color, specificity, and pH. You have done all these things in your practical, and you know the various significance of looking the volume, pH, appearance, order, color, etc. So that you can elaborate and write. I am not going to the details. Next, microscopic analysis is not very important in biochemistry, but just mention it, where the RBCs are usually very few or none in the normal urine. Then if there is plenty of RBCs, the condition is called hematuria, and it may be due to catheterization of urine for the passage of urine in obstructed urine passages. During menstruation, if you take the urine and examine, you will get RBCs. And inflamed prostate gland, any infection of the prostatic gland will produce bleeding, and that will cause hematuria, and you can see the RBCs. Similarly, cystitis, bladder infection, or any stones anywhere in the kidney, urinary bladder, or ureter, or urethra, even where there is injury, and then that will produce. And similarly, some malignancies in these urinary passages also produces hematuria. Okay. Now what are casts? Casts precipitated from the cell lining the renal tubules, and they may appear in the microscopy and containing RBCs called the red cell casts, and it is present usually when there is tubular bleeding. And white cells casts are seen in tubular inflammation, and epithelial cell casts are seen in degeneration and necrosis of the tubule cells. Then there may be crystals. Crystals may be seen in infection and inflammation, and also if there is any stones. So usually uric acid crystals can be seen, calcium oxalate crystals can be seen. So by that you can get an idea about whether what type of stone is present in the ureter or kidney. Then white blood cells white blood cells is also seen in the urine. That is usually seen in pyuria, urinary tract infection. That is any infection in the urinary tract, and also bacteria if there is any bacterial infection. Okay. Now, abnormal substance present in the urine, you have done all these things. I am not going to detail. Ketone bodies, bile salt and bile pigment, urobilinogen, reducing sugars for glucose usually, and the protein, major protein present in the urine is the albumin, and it is renal disease involving the glomerulus, usually produces proteinuria. Then, and about the markers of renal function, main thing is non-protein nitrogenous substance, that is urea, creatinine and uric acid are the major non-protein nitrogenous substance. Route of excretion of these substances are usually through urine. So the levels of NPN in the plasma will increase if there is any kidney dysfunction. Most important is the serum creatinine estimation. So renal marker of renal function is the main estimation is mainly the serum creatinine estimation. Remember always when you are asked in the Viva also you can say important test is the estimation of serum creatinine. Minor components of NPN are urobilinogen, indican, ammonia and amino acid. That is minor components. Major NPNs are urea, creatinine and uric acid. So you can estimate their levels because they are all excreted through urine. If there is any kidney dysfunction, their level in the blood may be increased. Now to estimate the GFR, that is to see the glomerular filtration rate, the markers of GFR is the clearance test. You know what are the clearance tests, and they are the predominantly the test for GFR, useful index of severity, assessing the severity of the renal damage. So very important test. A decrease in the renal function is due to the loss of functional nephrons. So usually the renal function is decreased when there is loss of functioning nephrons. So what is clearance? Clearance is the volume of blood or plasma completely cleared of a substance per unit time and expressed in ml per minute. And it is the ml of plasma which contains the amount of substance excreted by the kidney in a minute. So you studied all these things and just revising. You can write the definition of clearance and then go to the individual test. So there is a formula for calculating clearance test, that is UV by P, where U is the concentration of substance in urine, V is the ml of urine excreted per minute, and P is the concentration of substance in the plasma. If it is creatinine, you can say creatinine in plasma and urine, and the volume of urine per minute also you have to find out. Then if the substance is freely filtered and neither secreted or reabsorbed, then the clearance is equal to the GFR. So that is why we are telling that the clearance tests are the tests which is used to assess the glomerular filtration rate. So this is the ideal marker. It will be filtered, but it is neither secreted nor reabsorbed. Then it is called as an ideal marker. Inulin is actually the ideal marker, but not done routinely because it needs invasive procedures. And the best marker now we are doing is the creatinine clearance. So creatinine clearance is the best of all the clearance tests. Normal serum level of creatinine is 0.7 to 1.4 milligram per deciliter in plasma for adult male and 0.6 to 1.3 milligram per deciliter for adult female, and for children 0.4 to 1.2 milligrams per deciliter. So that level you have to mention, you have to study by heart. Then it can be combined with the creatinine in urine in 24 hours to perform the to get the value of creatinine clearance. Normal creatinine clearance 95 to 115 ml per minute in male and 85 to 110 ml per minute in female. So that also you have to study and write. Then we are passing on to the markers of glomerular permeability. Glomerulus actually act as a sieve, and macromolecules are restricted on the base of size, shape and charge. Usually macromolecules are not allowed to filter through the glomerulus. But in some disorders where the glomerular permeability is altered by injury or any other conditions, then the albumin and RBCs etc. will be excreted through urine. The normal urinary protein excretion is less than 150 milligram per day. And the proteinuria, when the protein pass through urine, it's called proteinuria. There are of various types: glomerular proteinuria, overflow proteinuria, tubular proteinuria, nephron loss proteinuria, or urogenic proteinuria. Just for the completion, I am mentioning all this. Then microalbuminuria. What is microalbuminuria? It is also known as paucialbuminuria. 30 to 300 milligram per day is seen in urine. An early morning sample is tested. Usually for finding out the microalbuminuria, you have to take the early morning sample. And it is an indicator of nephropathy in diabetes mellitus and hypertension. So this test is usually done at least once in a year. Even 6 months interval also you can do to assess whether the patient is developing nephropathy, which is a complication of diabetes and hypertension. Then it is expressed also as a albumin creatinine ratio, and the ratio is if less than 23 milligram per kilogram creatinine in male and 32 milligram per gram of creatinine in female. So that AC ratio you need not study because it is the latest thing and it is not very important for you. Anyway, normal level is less than 23 milligram per gram of creatinine in male and 32 milligram per gram of creatinine in female. Then test for tubular function. So in early disease of the kidney can be detected by assessing the tubular function. So important one is the specific gravity that you have seen in the first physical examination itself, and it's the simplest as using urinometer you can find out the specific gravity, and it is an indicator of osmolality, and specific gravity depends upon the concentration of solutes and osmolality depends upon the osmolaltically active particles. In proteinuria, specific gravity increases but osmolality increases only mildly. And the earliest manifestation of renal disease is the difficulty in concentrating the urine. So that is why we are doing the concentration test and dilution test in the urine. Normal value ranges from 60 milliosmol per kg to 1200 milliosmol per kg. That is the specific gravity normally, and the plasma osmolality normal osmolality. So normal level of osmolality varies from 60 to 1200 milliosmol per kg. Then plasma osmolality is 285 to 300 milliosmol per kg. Now the concentration test. No food or water after a meal at 6 p.m. and the patient may be fasting and the urine avoided at 7 a.m. and discarded, and second sample is collected at 8 a.m. and specific gravity measured. Normal specific gravity 1.022 and the osmolality 850 milliosmol per kg. As the disease progresses, specific gravity will be fixed to 1010, that is 1.010, and the 300 milliosmol per kg osmolality, that is called the isospinoria. So as the disease progresses, it will go on and finally fixed it to 1010 and the osmolality will be 300. And the early morning specific gravity normally is above the 1.018. That is the normal concentrating capacity. So early morning sample, if you examine the specific gravity, usually above 1.018, that is usually 20 or 22, that is the normal specific gravity. Normal night volume is measuring the urinary volume in night and day is another important test to assess the concentration power. Normally, night volume is only half of the day volume. So nocturia is a sign of early tubular dysfunction. So usually night volume is only half of the day volume. If there is excess urine in the night, that is another indication for the tubular dysfunction. Then dilution test. More sensitive and less harmful test. Patient is not allowed to drink water after midnight. Bladder is emptied at 7 a.m. and 1200 ml of water is given in 30 minutes, and the hourly urine sample is collected separately for the next 4 hours. So estimate the volume, then specific gravity and osmolality of each sample. So here first you have to make the patient fasting till after midnight, and then early morning sample is emptied, and then he is given 1200 ml of water in 30 minutes. Then take the hourly sample and examine the volume, specificity and osmolality of each sample. Normally, all water will be excreted, and specificity of at least one sample should be at least 1.003, and the osmolality is 50 milliosmol per kg. So when after dilution, at least one of the samples should have a specific gravity of 1.003 and the osmolality of about 50, minimum of 50 milliosmol per kg. Then urinary acidification, that is done with in unexplained renal tubular acidosis that usually occurs in hyperchloremic acidosis. And the acidification defects are occur due to the tubular defects or genetic disease of the iron pumps. It can be either due to the tubular defects or due to genetic defects of the iron pumps. So here what is doing is ammonium chloride is given in a dose of 0.1 gram per kilogram or 100 milligram per kilogram body weight as an enteric coated preparation, and the urine collected from 2 hours to 8 hours hourly after the ingestion, and the pH and the acid excretion of each sample is noted. So first you give the enteric coated tablet 0.1 gram per kilogram body weight, and after that 2 hours after that you have to collect hourly samples and examine the pH and acid excretion of each sample. Normal value of pH is 5.3, and the ammonia excretion usually will be 30 to 90 millimoles per hour. But in tubular acidosis, the pH 5.3 is not usually achieved. So in that condition, this usually acidity pH will not be achieved in 5.3. So in chronic renal failure, the low pH and the ammonia excretion is less. pH is low, and then there will be ammonia excretion also is less. So that is the importance of doing urinary acidification test, usually done in renal tubular acidosis. That is usually chronic renal failure, the low pH and the ammonia excretion is less. Next, in this table, I have given all the values. You can refer and study urea, what is the normal plasma level, urinary excretion, and factors affecting. Urea 15 to 40 milligram per deciliter, excretion 15 to 30 grams per day. Factors affecting dietary protein, catabolism, and renal blood flow. Then creatinine 0.7 to 1.4 milligram per deciliter in male, 0.4 to 1.3 milligram per deciliter in female, and excretion 1 to 2 grams per day. And factors affecting is the glomerular filtration rate, tubular secretion, age, sex, and muscle mass. Then uric acid 3 to 7 milligram per deciliter in male, 2 to 5 milligram per deciliter in female, 0.5 to 0.8 grams per day in urine, and the factors affecting purine catabolism and tubular excretion. Then sodium, it's an electrolyte, 135 to 145 milliequivalents per liter. Factors affecting status of dehydration, dietary, sodium, and the renal function. Potassium 3.5 to 5 milliequivalents per liter, dietary and acid base balance and renal function. Calcium 9 to 11 milligram per deciliter. Factors affecting dietary calcium, parathormone, calcitonin, and the renal function. So this is the nutshell of the renal function test. You can write, study, and refer, concise and write, and whatever thing important you have to write elaborately. Just don't write the names of the test and finish it off. Okay, thank you.